Hello, everyone. My name is Lindsay Sletton, and I want to thank you today for taking the time to listen to our presentation regarding fire safety in young children. As I said, my name is Lindsay Sletton. I am the emergency room clinical educator. I wanted to introduce each team member. We brought together a very passionate and highly qualified team, and then we'll get started with our plan for health intervention. We have Audrey Fimbris, she's the pediatric clinical educator, Melissa Davis, the emergency room director of nursing, and Lisa Jopi, the pediatric clinical nurse specialist. By the end of this presentation, our audience should understand the justification for why we chose our intervention, the components and supplies needed for our health intervention plan, the theory used as a groundwork for our intervention, how we will evaluate the effectiveness of our intervention, a rough cost estimate, the resources needed that need to be utilized in this plan, and then finally for the future of this project and how we will promote its sustainability. The group that we are serving with this intervention is first, second, and third graders in the school district that surrounds DHRA. Families in this area are middle class in the income level, and Audrey, our pediatric educator, will speak to the group about the justification for our project.
Thank you, Lindsay. Hi, my name's Audrey. As she said, I'm the pediatric educator, and I'm just going to talk to you for a little bit about some injuries that happen in this young child population. Unintentional injuries are a serious issue for the young child population, as are the consequences. These injuries include motor vehicle accidents, falls, poisonings, suffocations, drownings, and fires and burns. According to the CDC, unintentional injuries are the leading cause of mortality in children throughout the world, so this is not just an issue in the United States, it's also shared globally. 16 million children each year are seen in emergency rooms due to unintentional injuries. Also, every 1.5 minutes, an infant is brought into an emergency room because of the unintentional injuries. The problem that we chose to address with our intervention is fire-related injuries. Fire-related injuries are one of the many types of unintentional injuries that affect children all over the world. I am going to tell you about some facts about these injuries that are affecting our children. The CDC reports more than 300 children are evaluated for burns in the emergency rooms across the United States. These fires and burn injuries are the third leading cause of death related to injury in children under the age of 14. Most fire-related deaths result from home fires and are due to inhalation of smoke and other toxic gases. These house fires occur more frequently in the winter months because of Christmas trees, space heaters, and fireplace malfunctions. In homes where a fire occurred with a working smoke detector, the risk of death was reduced by 40 to 50%. Many of these unintentional injuries are preventable, and nursing has an active role in the health promotion and risk reduction with these injuries. The nurse should and could provide education regarding risk and prevention practices to the family. She can also provide resources to these families that are seeking to make positive changes to reduce the risk of injury to the children in their household. It's also very important that healthcare professionals such as nursing continue to provide support to each patient and family that choose to make these positive choices and changes to reduce the risk and prevent these unintentional injuries in their household. Next, Melissa Davis, our Director of Emergency Services, is going to talk to you a little bit more about our intervention.
Hi, thank you, Audrey. Like Audrey said, I'm going to discuss some of the objectives of our intervention. We want to increase the awareness of how frequently childhood injuries occur, especially those related to fire, to teach kids what they can do to prevent fires and to recognize common fire and safety hazards in their homes, to teach kids what to do in case of fire, and to give them the tools to develop a fire plan in their home. We also want to increase the number of families who state that they have working smoke detectors in their homes during intake assessments at DRHA by 5% in the first year, and we want to reduce the number of burn injuries seen in our emergency department each month by 3% during the first year. So we developed this intervention based on a health assessment that we developed for our community. The screening tool was a 74-question assessment of 8 domains of health. The assessment was designed to assess both parents and young children, and the tool was adapted from a combination of Gordon's functional health patterns and the American College of Medicine's Child Injury Assessment Tool. The questions assessed risks of injury related to fire included, are there working smoke detectors in the home, and what do you do if there is a fire? All the families stated that there were functional smoke alarms, and one even affirmed that they were regularly assessed. However, only one family had an actual plan in place that the child could verbalize of what to do in case of a fire. So we definitely found a knowledge gap, and this is supported by the American Red Cross, that in a study found that 52% of families have not discussed fire safety, and 62% of parents believe that they have 5 minutes or more to escape a house fire. Experts actually say that it's closer to 2 minutes to escape, and 70% of families haven't identified an area to go to if there were a house fire. Some of the literature points to the effectiveness of these kind of interventions. Injuries, first and foremost, are predicted and prevented through collaborative efforts. So safety education needs to be a partnership between schools and community resources, and those have been shown to be successful in long-term development of safety skills in young children. Other studies have shown that behavioral reenactment programs have been very successful in increasing the knowledge level and behaviors related to safety in young kids. Programs such as Stop, Drop, and Roll have been highly effective. Another study showed that positive results and increases in knowledge were obtained after just 45 minutes of a computer game that taught fire safety. So Lisa is going to discuss a little bit more about the framework of our intervention. Thank you, Lisa.
Thank you, Melissa. The theory that we chose to frame our intervention is the health belief model. This states that an individual will take action to change if there is a perceived threat to personal health, and that the benefit of said action outweighs any barriers involved. Susceptibility and severity combine to produce the threat of injury. Susceptibility reflects feelings of vulnerability of risk of injury. Seriousness is the degree of emotional arousal at the thought of injury. Perceived benefits include beliefs about the effectiveness of the action in preventing the threat. Barriers are the ideas of negative aspects of taking action, such as time and inconvenience. Self-efficacy is the person's confidence that they do have the ability to take action. In our case for fire prevention, the perceived threat is injuries, burns, or death from fire. What do children know are safety issues that may cause a fire? Do parents know the risk involved to children if no fire safety plan is implemented? How much they know can then form the basis of behavioral change. Educating children and their families on fire prevention can help show that the benefits far outweigh any barriers that may be involved and can give children the confidence in fire prevention. Our fire safety intervention will be a 30-minute presentation about common fire hazards using the Hazard House simulator. The Hazard House is a 3D portable unit designed with many fire hazards located within different rooms with lights that simulate a fire with smoke. It has a remote control for instructor use. Before a presentation with Hazard House begins, children will take a pre-test to test prior knowledge of fire safety. The test will be based on learning level and will consist of 10 to 12 items. Through Model Tech Incorporated, training will be given to the nurses and nursing students on how to correctly use Hazard House props in a typical presentation. The program consists of a 30-minute presentation about the dangers of common fire hazards, such as matches, cigarettes, non-working smoke alarms, electrical outlets, using electrical items near water, as well as how to remedy those hazards, what to do, and who to call if a fire does start. The children will be able to identify home hazards using Hazard House and see a simulated fire using lights and smoke. After the presentation is done, the children will take the same test to test the increase of their knowledge from the presentation. Children will be given a flyer with presentation information to take home for continued learning. Materials include, this is an example of a presentator instructions for the pre-post test for first and second graders. As you can see, there are simple questions and answers based on their level of learning. Questions include, what would you do if you found matches on the table, and what would happen if someone smoked a cigarette, cigar, or pipe in the house? This is the answer form for the first and second grade test. As you can see, the children only need to circle the correct answer. This is the pre-post test for third graders. The questions again are based on learning level. Questions include what is the #1 cause of house fires and what should you do if you cannot get out of a room because the only door is hot. Other materials needed for this intervention include the Hazard House Simulator, the flyer for take-home learning, 3-month follow-up test, and a parental survey. Our evaluation for intervention knowledge will include the pre-post tests given at time of presentation. After 3 months, the same test given at time of presentation will be sent out to test long-term knowledge. A parental survey will be also given for parental feedback. This parental survey will be a simple survey asking, in the last 3 months, how often did you and your child speak about 911? Have you created a family fire safety plan? And does your child understand the plan? And how often have you and your child spoken about fire safety? Some DRHA resources that can be helpful with our project include the Burn Center volunteers and the Nursing Educator Coordinator. Burn Center employees can offer education to us to help increase fire safety awareness. Volunteers can be utilized to process materials and during presentation assist with any needs that may arise. We will be partnering with the university to use nursing students for this project, so a strong resource will be the Nursing Education Coordinator. I will be bringing it back to Melissa to continue with the presentation.
Thanks, Lisa. So looking at our budget, the projected costs in 2016, the largest expense is going to be the purchase of the actual Hazard House equipment, which is projected at about $3,500. The other costs are related to printing materials. The printing will be provided by uprinting.com for a very reasonable cost. It'll include the educational flyers for the children to take home. That'll include the tips and how to make a fire safety plan, the cost of the printing of the pre and post tests, and follow-up surveys. We've also budgeted for some print advertising in the form of posters that'll be in the pediatric areas and in elementary schools, and for stickers to give out to the kids during the sessions and at other DRHA community events. We also have included a small budget for some social media advertising to bring some awareness to our campaign in the community. This will total about $9,505 for the first year. Looking at the sustainability of our intervention, we think it's highly sustainable. This is going to be a very fun project, and we think it'll be very engaging for the kids. It's going to be cost effective. The program will run on community collaboration. We've already worked with the university to recruit nursing students that are in their public health rotation and pre-nursing students that need volunteer hours. They have agreed to set up as part of their project to help us on a continuing basis with this program. We're also going to be partnering with local fire stations. They have expressed interest in starting programs on their own but don't have the resources to maintain a program. So with collaboration with DRHA, we should be able to maintain a program. And like I said, it's low cost. Most of the equipment will be a one-time cost in that first year. In subsequent years, it'll be the cost of printed materials. In the first year, we hope to reach 5,000 kids, but we think we will be able to increase that as years go on and we see the effectiveness of our program. Again, we want to thank you for your time. If you have any questions, please let us know.